Welcome to the Health Headliner podcast by Tudu Digital. Our content is informational only and not medical advice. Please consult your provider. Now, let's dive into today's headlines.
Welcome back to the deep dive. Today, we're looking at something that feels both ancient and startlingly current. A disease we thought we had under control, syphilis, is making a comeback, a big one. The statistics are, well, frankly, they're alarming. In 2023, the U.S. saw over 209,000 total cases. That's up 61% from just 2019.
Which is already a huge jump.
Exactly. But the really heartbreaking part is congenital syphilis, passed from parent to baby. Nearly 3,900 cases. That's shot up 108% in the same time frame. Just staggering.
It really is a tragedy because syphilis isn't just a minor issue. If it's not treated, it can cause severe neurological problems, damage to the heart, the brain, and in pregnancy, the complications can be devastating, serious, often permanent issues for the baby. Plus, it significantly ups the risk of getting or passing on HIV. So yeah, it's a major public health priority.
Right. And for decades, the main weapon we've had against it is an antibiotic, benzathine penicillin G, or BPG.
Yep, the gold standard since around the 1950s, highly effective.
But there are catches. Big ones. Globally, getting enough BPG is often a problem. Stockouts happen.
They do. It cripples efforts sometimes.
And the standard treatment itself, particularly for early syphilis, usually meant 3 separate shots, 1 injection every week for 3 weeks. Imagine coordinating that, fitting it into your life.
Oh, absolutely. It's not just the discomfort of the shots themselves, which are not pleasant. It's a logistical hurdle. People miss appointments. They don't complete the course. Adherence is a massive challenge. And on top of that, there's been this long-running debate among doctors, especially about treating people who also have HIV. Should they get the standard 3 doses or maybe even more? There was a lot of uncertainty, a feeling that maybe 1 shot wasn't enough for them.
So you've got rising cases, supply issues, treatment being a burden. It makes you wonder, right? Could there be a simpler way? What if we could ease that burden, maybe with just 1 shot, without losing effectiveness?
Exactly the question.
And that's what we're diving into today. There's been a really important clinical trial looking at precisely this. We'll be digging into a recent health news piece and the detailed study behind it from the New England Journal of Medicine.
Yeah, this study aimed to settle that controversy about how long the treatment needs to be for early syphilis, especially with HIV in the picture. They designed what's called a multi-center, randomized, controlled, non-inferiority trial.
Okay, non-inferiority. What does that mean in simple terms?
Right, so it doesn't try to prove the new way is better. It tries to show it's not worse than the standard treatment by a specific amount they decide beforehand. Basically, is a single dose essentially just as good as 3.
Got it. And this was done across the U.S.?
Yep, 10 different locations. Pretty robust.
So who took part in this trial?
They had 249 people with early syphilis. So that includes the primary, secondary, and early latent stages, the initial phases.
And the demographics?
Well, it was heavily weighted towards men, 97% of participants, and crucially, 61% were living with HIV.
Okay, so really relevant to that group where there's been all the debate.
Exactly. They did exclude some people, like pregnant individuals, anyone allergic to penicillin, or if neurosyphilis was suspected.
Makes sense. So how did the treatment actually work in the trial?
Okay, so participants were randomly put into one of 2 groups. Group 1 got a single shot intramuscularly of 2.4 million units of BPG. Group 2 got the standard 3 weekly shots, each one also 2.4 million units.
And how did they measure if it worked?
They looked at what's called the serologic response after 6 months. Essentially, they checked blood tests. Success meant either the tests became non-reactive, the infection cleared, or there was a big drop in certain markers, specifically at least a 2 dilution decrease in things like the RPR titer, a common syphilis test.
2 dilution drop meaning like a significant reduction.
Yeah, basically the level of those disease indicators in the blood went down enough to clearly show the treatment was working.
Okay, so here's the moment, right? What did they find? Was 1 shot enough?
This is really the core finding, the big takeaway. The results were pretty striking. In the single-dose group, 76% of people showed that successful serologic response at 6 months.
76%. And the 3-dose group?
70%.
Yep.
70%.
Wow.
Yeah.
So very similar.
Exactly. Statistically, there was no significant difference between the 2. The trial clearly showed that the single dose was non-inferior. It was just as effective as 3 doses.
And critically, did anyone relapse or have the treatment fail?
No, not in either group during the study. No clinical relapses, no treatment failures observed.
That feels like a really big deal. 1 shot instead of 3. The implications seem huge.
Oh, it really is. Think about it. Fewer clinic visits, less discomfort, much easier for people to actually complete their treatment. It tackles that adherence problem head on.
But hang on, what about the HIV factor? That was the big point of debate, wasn't it? Did the single shot work as well for people living with HIV?
Yes, and this is probably one of the most important parts of the study, challenging that old way of thinking. The effectiveness was consistent. For people living with HIV, the response rate was 76% with a single dose versus 71% with 3 doses.
Practically identical to the overall result.
Pretty much. And for those without HIV, it was 76% for 1 dose, 70% for 3. Again, very similar.
What about people whose immune systems might be weaker, say lower CD4 counts?
Good question. They looked at that too. Even among participants with CD4 counts below 200, which indicates more significant immune suppression, the response rate was still strong, around 69%. So this really provides strong evidence against the idea that HIV-positive individuals automatically need more intensive therapy for early syphilis.
That's fascinating. So moving beyond just the effectiveness rates, what about the patient experience? Did one dose feel different?
Well, the main side effect reported was pain or tenderness right where they got the shot.
Makes sense.
And as you'd expect, more people in the 3-dose group reported this, 85%, compared to 76% in the single-dose group.
So less overall discomfort with just 1 shot.
Right. And maybe more telling is this. 17% of the people assigned to get 3 doses didn't actually get all 3.
17%. That really shows the difficulty of sticking with that longer regimen in the real world.
Absolutely. It highlights that adherence issue we talked about. Life gets in the way or it's just too burdensome.
You also mentioned something interesting earlier about a reaction some people had.
Ah, yes, the Jerisch-Herxheimer reaction. About 24% of participants experienced it after the first dose. Things like fever, maybe a rash, aches. It's basically the body reacting as the bacteria die off. But here's the twist.
Yeah.
People who had that reaction were actually more likely to show a successful serologic response later on. 85% of them responded well, compared to 69% of those who didn't have the reaction.
Huh. So it's unpleasant, but maybe a sign the treatment is really kicking in hard.
Seems like it, yeah. An odd indicator of success.
So let's pull this together. What are the big implications here? Obviously, simplifying treatment is huge.
It's transformative, potentially. 1 visit, 1 shot. It dramatically lowers the burden on the patient, fewer missed work days, less travel, less pain. It makes completing treatment much more likely.
And easier adherence means better public health outcomes overall.
Definitely. Dr. Carolyn Deal from NIH really emphasized this point. She said, the 3-dose way can be burdensome. People drop out. And these findings offer welcome evidence for simplifying things with 1 dose, especially with syphilis rates so high. It's about making effective treatment practical.
It also seems important given those BPG shortages you mentioned earlier.
Absolutely critical.
Right.
If you only need 1 dose per patient instead of 3, your limited supply goes 3 times further. That's huge for resource management globally. It's good antimicrobial stewardship using our antibiotics wisely.
And it helps fight those rising infection numbers more effectively.
Exactly. It gives us a much more efficient tool in the toolbox.
And it sounds like this study really validates the existing CDC guidelines, even for people with HIV, where maybe some doctors were hesitant before.
It provides very strong evidence supporting those single-dose recommendations. It should help clear up that clinical uncertainty and push towards more consistent evidence-based practice. Like the lead investigator, Dr. Hook, said, we've been dealing with syphilis for over a century, but we're still learning how to optimize treatment. This is a big step in that optimization.
Okay, but like any study, it can't answer everything. What are the limitations here? Where do we still need more information?
Right, important to acknowledge that. A major one is the lack of women participants. Very few were enrolled. So we can't confidently say these results apply equally to women or, crucially, to pregnant individuals.
Which is a huge gap, given the surge in congenital syphilis.
A massive gap. We desperately need data specifically for pregnant people. Also, the trial focused only on early syphilis. It excluded people with late-stage disease, latent syphilis of unknown duration, or neurosyphilis. So the findings don't apply there.
And what about the HIV-positive group? Any nuances there?
Well, most of the HIV-positive participants were already on effective antiretroviral therapy, RT, and had relatively high CD4 counts. So we have less data on how this works for people with untreated HIV or very advanced immune suppression.
Got it. You also mentioned the way success was measured, the blood tests. the serologic response isn't perfect.
Yeah, that's another key point. Relying on those RPR titers takes time, months sometimes. And even then, about 20% of people might not show a significant change even if the treatment worked. It leaves this period of uncertainty. We really need better, faster ways to know if the infection is truly gone.
So better diagnostics are needed too, not just treatments.
Definitely. Improved ways to detect active infection and measure treatment response accurately and quickly are high in the research wish list.
And what about future research directions based on this?
Well, clearly, we need studies that include women and pregnant individuals. That's paramount. We also need to evaluate treatments for all stages of syphilis, including the later stages excluded here. And, a big one, finding effective alternatives to penicillin. Up to 20% of people report a penicillin allergy. We need good options for them too.
Okay, so recapping the main aha moment. This study strongly suggests 1 shot of DPG is as good as 3 for early syphilis, even in people living with HIV.
That's the core message. Simpler, equally effective.
Which means less burden for patients, likely better adherence, and smarter use of antibiotics, especially when supplies are tight and cases are rising.
Exactly. It's a win-win-win, potentially. It's just fascinating, isn't it? A disease we've known about forever, yet we're still finding crucial insights that can really change how we manage it today. It's a great reminder that we should always question long-held practices, even in medicine. Are they still the best way?
That's a powerful thought to leave with. It makes you wonder, where else are we sticking to complex routines, maybe in healthcare or other fields, just because it's always been done that way? Could simplicity be just as good or maybe even better? Something to think about. Keep exploring, keep questioning those assumptions. Thanks for joining us on the Deep Dive.
Thanks for tuning in to the Health Headliner podcast by To Digital. Like and subscribe for more health news and breakthroughs. Stay healthy and informed. See you next time.